All right, let's review bronchiolitis for a little bit. So the differential for bronchiolitis would be asthma, bacterial pneumonia, chronic pulmonary disease, foreign body aspiration, heart failure or congenital heart disease, and vascular ring. You will most likely see asthma and bronchiolitis and pneumonia compared to each other. Predisposing conditions for bronchiolitis, usually we see this in patients less than 2. And this is a seasonal illness, so you're going to see it in the late fall or winter. Risk factors for those who are going to get the most sick from bronchiolitis, if there's a history of prematurity, less than 36 weeks of age, low birth weight, if the patient themselves are less than 3 months of age, if they have underlying comorbidities such as pulmonary disease, anatomical defects of the airway, heart disease, immune deficiency, and neurologic disease. So the pathophysiology behind this, the virus infects the terminal bronchioles. This causes inflammation, edema, mucus, sloughing of the epithelial cells, which then causes obstruction of the airways and atelectasis. The causes of bronchiolitis, RSV is the one you'll hear about the most and probably be tested on, but just know clinically that numerous viruses can cause it as well, such as rhinovirus, parainfluenza virus, and metapneumovirus. Clinical manifestations, so this usually starts with URI symptoms and then progresses to the lower respiratory tract. So you'll then have cough, congestion, retractions, and then migrating crackles and wheezes. And so the migrating crackles and wheezes is a really key feature when you're trying to differentiate bronchiolitis with a bacterial pneumonia. A bacterial pneumonia is going to be very localized and it's not going to move around. On day 3 are when the symptoms usually get the worst for bronchiolitis. And then remember, you can see apnea in patients that are born premature or if they're younger than 2 months of age. And sometimes this is a good test question as well. So when you evaluate asthma, just remember that it's diagnosed clinically. We do have labs available to diagnose it through rapid testing, but we typically don't use them. And it's really not something that needs to be diagnosed by chest x-ray either. So the only time that we do these studies or extra studies is if we're worried about complications related to bronchiolitis. So maybe if the patient's dehydrated, we'll get electrolyte studies. Maybe if we're worried about a secondary bacterial pneumonia, then we'll get a chest x-ray, but otherwise we don't do anything. As far as treatment goes, the shelf exam likes to trick you into coming up with different treatments, but really just remember most things don't work. So when you look at steroids, albuterol, antibiotics, leukotriene inhibitors, they all have been proven not to work. You may see in some bronchiolitis patients, the physician trials albuterol, and then if the patient's requiring this frequently, they may start the patient on steroids. So the key here is that they're not treating the bronchiolitis itself, but they're treating the reactive airway disease or asthma that's being exacerbated by the bronchiolitis. What's been shown to work is basically things that help relieve the obstruction that's caused by that pathophysiologic process that we talked about. So suctioning, IV fluids can help prevent dehydration. We do like to keep the patients NPO if they're breathing faster than 60 times a minute, otherwise they're at risk for aspirating. We give them oxygen through many different modes of delivery. We can do it by standard nasal cannula. We also have something called the high flow nasal cannula, which basically increases the positive pressure and the volume of oxygen that they're getting. We're allowed to do that on the general peds floors under certain parameters, but if patients fall outside of those parameters, then they have to transfer them to the ICU. And then we use CPAP and sometimes intubation as well. And again, those are done in the ICU too. Typically, some patients may get nebulized hypertonic saline. This is thought to work by drawing the secretions out into the airway to where they can be suctioned. You may see other things like IPPB, which is just positive pressure given intermittently, and that helps expand the airways and expand the lungs. Again, going back to that pathological process of obstructing the airways and having atelectasis. So this concludes our talk on bronchiolitis.